long-term ventilation.
Very good. Long-term ventilation. It says on the slide, consider after 12 days of being intubated, but it could even be a week. If they've been intubated for a week and you're unsuccessful at getting them off the vent, you may choose to treat the patient at that point. So that first bullet, relieve an upper airway obstruction. If there is a tumor, I guess, in the vocal cords and it's obstructing the airway, one of those big things, those big growths that you got on the side of the airway, from the thyroid gland.
Goiter?
Yeah, that can push and obstruct the airway. So anything obstructing the upper airway would be reason for having a tracheostomy. Also, if a patient has an inability to cough or clear secretions, it's just kind of setting them up for airway obstructions. They're going to be sad. They're going to get pneumonia. They're going to end up on the ventilator. So let's treat them. 25% of all ventilated patients end up being tracheostomy. There's different types of tracheotomies. The first one mentioned, it says is surgical. And this is done in the OR, where they actually remove the second and third tracheal rings. They cut them out and make room for the trach tube to go in. It's easy for the surgeon to visualize the tissue and placement in the trachea because they've got this big wide opening when they do that. The next type of tracheotomy is bedside, also called percutaneous tracheostomy. Percutaneous because they put a hole right through the skin and into the cartilage. This is better than removing the tracheal rings. There's lower risk of hemorrhage and infection. The incision is made between the first and second tracheal ring. So they start with a small catheter, and then they use a dilating catheter to stretch the opening. Then the catheter will increase in size to enlarge the opening for the trachea. And then cricothyrotomy is usually done as an emergency by paramedics, not done in the hospital. What are the risks of doing a tracheotomy? Bleeding, of course, infection. The next one is tracheostenosis can occur, and this is narrowing due to scar tissue. So when you have an opening, a surgical opening, it stimulates the body to kind of protect that and heal it, and it sets down all this tissue that becomes scar tissue. And the scar tissue takes up space, and having that scar tissue in the airway narrows the airway. So that's one of the downfalls of having a tracheostomy. The laryngeal nerve runs alongside the trachea, and it's possible to damage the laryngeal nerve during the procedure. A fistula may also occur. There are risks of just keeping a patient intubated with an endotracheal tube. Microaspiration occurs even if we have good cuff pressures and we're really good about suctioning the upper airway, keeping the airway disinfected, or keeping the oral care using disinfectant. Doing all those steps, they can still get a pneumonia from being intubated with an endotracheal tube. And it's because the epiglottis is kept open at all times. So when they go to swallow, their epiglottis can't close because the endotracheal tube is in there. So any oral secretions can sit on the cuff and still get around the cuff even if you have the cuff inflated. Another risk is possible extubation and loss of the airway. Why is that not a risk with tracheostomy?
well, the trach bags and sewed in when it first gets going. It's less likely.
Yeah, they literally sew it to the skin,
Yeah.
so the trach tube can't come out. The tube moves with head movement about 3 to 4 centimeters, which is why it's important to keep it 3 to 4 centimeters at least above the pharma. An overinflated cuff can damage the tracheal mucosa. But that would hold true for having a trach tube in also, wouldn't it? You overinflate the trach tube, overinflate the cuff, you're gonna damage the tracheal mucosa. The tube is uncomfortable like that. Once the trach tube goes in and we either have a little deflation of the cuff to let some air come up through the mouth, or we have a passing ear valve on, then we can speak. So it said less sedation is needed when the patient is trached. It's safer because the tube is sutured to the neck, so there's less chance of the tube coming out. And there is less draw, which is referring to airway resistance. So having an endotracheal tube in, it's long, and breathing through that long of a tube, there's a lot more resistance than breathing through a short tracheostomy tube. The other problem with endotracheal tubes is if they go in the mouth this way, I know I told you this during the chemical ventilation, but the tube goes in the mouth and then it's in the trachea, which means it has to make a curve in order to get to the trachea. And when you curve an endotracheal tube, you narrow it. So it's a lot narrower in the back of the throat, and then you're trying to wean the patient off the ventilator. It's really hard to get them off. They're working really hard to breathe, and then they get trached. And then the next day, they come off the ventilator. And that's because the tube was the problem. That's what was preventing them from coming off the ventilator. They just had to work so hard because of that narrow tube. Cuff pressure should be measured every shift. Keep cuff pressures less than 32 centimeters of water to avoid ischemic tissue. So the 32 centimeters water is capillary pressure. No, that's arterial pressure. I think capillary pressure is a little bit lower. So to have arterial blood flow to an area, your pressures have to be less than 32 centimeters of water. So, can you just have as low of a pressure as possible in the cuff? And the answer is no. You want to keep at least 18 centimeters of water in there to prevent aspiration of oral secretions. It doesn't completely prevent it, but it diminishes the amount. It takes 5 to 7 days for the tract to heal and form. So if the tube comes out, do not reinsert it if it's within the first few days. Instead, you cover the stoma with a Vaseline gauze, and that will create a seal. And then you intubate with an endotracheal tube. The first tube change should take place after 2 weeks by the surgeon. So it's up to the surgeon to cut the sutures, take the tube out, and then put another tube in. So some trach tubes do not have an inner cannula, so they're all one piece, and that's typically what they go home with. So your long-term kids are just going to have that one piece trach tube. And here it says it should be changed every 2 weeks. So communication with a tracheostomy. After suctioning of the cuff can be slightly deflated to allow the patient to talk. Or you can use a passing ear speaking valve, and of course you have to deflate the cuff. Not deflating the cuff will cause suffocation. So specialized trach tubes. There's 2 types. There's extra length tubes, and it can be extra length going down the trachea or extra length coming from the trachea outward. There's also adjustable length trach tubes. Have you come across those at all?
For when they have
I've heard of them, but I haven't.
or something, where
No, instead of it being extra long and that's it, you can adjust how far down it goes into the trachea. Or you can pull it back a little bit.
Yeah, I think we've seen a little bit.
Yeah. And then there's TTS, which is a special type of flexible plastic that's really close to the trach tube, so it's easy to get the tube in to these kids that have small openings, but it does inflate normally. So it says the cup is close to the shaft of the trach tube, which makes it easier to insert. And then you have cups where you don't fill it up with air, you fill it up with saline.
Yeah.
And the thought is that it's softer against the tracheal wall. You can't measure pressure when you put a liquid in the trachea. Cup. And then for the specialized trach tubes, I think it shows a picture of everything I just talked about. So picture A is showing how long the tube is between where it enters the neck and goes to the trach tube, and then it comes down in normal length. B, it's normal between where the neck is and the trach, but it's a lot longer, so it goes past the narrowing, showing a narrowing when it gets past it. So which one is proximal extension and which one is a distal extension? Do you think A is proximal or distal?
I think A is optional.
You are correct. And letter B is distal extension. Very good. And then over on the right by itself is the trach tube where you can adjust the tube and then securing it again so it doesn't move around while it's in fusion. Also, notice how different it looks for the pilot balloon to be filled with saline. It has a little bit of a different shape than the cups that we're used to seeing on endotracheal tubes.
I think it was harder to suction with those types. I don't know why. It was, to get the catheter in was a little bit tricky.
They kept getting stuck on these metal rings.
Maybe that's what it is.
Yeah, that could be. And then the last slide talks about decannulation. So at what point do you decide it's time to take the trach tube out, let the stoma heal, the patient came off the ventilator, they're doing well? And here it says they need to be off the ventilator for 2 days. You have them on the trach collar. First thing to do is deflate the cuff and make sure that there's no upper airway obstruction so they can breathe through their mouth and have no problems. It sounds impossible, doesn't it, to have a tube sitting in your trachea and then you're supposed to breathe around it to say that you're fine. So there's got to be some resistance to breathing when the trach tube is still in there. So you deflate the cuff and plug the trach tube, and it says the patient should be able to breathe through their upper airway without distress. They should also be able to cough and clear secretions on their own. So if they can't clear their secretions, then they still need a trach tube. Next thing, downsize the trach to the next smaller size. That way you've still got an airway in case anything goes wrong, but at least now it's easier for them to breathe around it so that you can go one step closer to taking it out. Cap the trach. Can you leave the cup inflated for that? No. So you cap for 4 hours or as much as they can tolerate at first. Once you can keep the cap on for 8 hours and they're fine, then they're ready for decannulation. So you pull the trach tube out, of course with physician order. and put Vaseline over the stoma, and it closes within a few hours on its own. So if you take it out and the patient gets into distress, even within a few hours, you can't get the trach tube back in. It's gotta be an oral intubation at that point. So that tissue just kind of closes in on the opening and you can't really use it.
And no matter how long they've been trached, they all close that quickly.
Yeah.
That's pretty cool.
So how do they have the permanent stomas that stay open?
I think surgically.
Okay.
So some notes or some questions that you might come across. 3 days post-trach, the trach tube comes out, what do? You good to go with that one?
Yeah,
Cover the stoma and
with Vaseline, then intubate.
Yes, very good.
Vaseline does.
How long before you would change a trach tube? 2 weeks. The first one. How could you identify if there's upper airway obstruction prior to plugging the trach?
And,
That's kind of obvious,
and
isn't it?
preserve resistance. Huh?
Yeah, you would see the person struggle, right?
Mm-hmm.
If you plate the cup and put a cap on it and you say, pretty obvious. What is the difference between a trach cap and a trach button?
Wasn't it some trach button?
Trach button?
Oh, but I don't know. I did the same.
No. So a trach button maintains the stoma after the trach tube comes out. So a trach button maintains the stoma. In case they need to have the trach tube with them. When you measure cuff pressure, is it in millimeters mercury or centimeters of water?
Centimeters.
Yeah. It's centimeters of water. Which is more pressure, centimeters of water or millimeters of mercury?
It says 1 millimeter mercury is equal to 1.36 centimeters of H2O.
Okay, so centimeters is greater.
How would you know if a TE fistula has developed? So TE is between the trachea and the esophagus, tracheoesophageal fistula. How would you know if a fistula has developed?
Even air leak?
What about food getting into the
Trach.
aspiration?
Would it cause a hard time breathing too? Like before the aspiration, you will see the patient, because the patient will not get the volume that the patient is trying to get, right? So
Like
they
if
would.
you have them on the ventilator and a TB fistula develops, some of the air from the ventilator goes through the esophagus.
Yeah.
Yeah, that's true. Yeah. Okay, I think those were all the questions. TTS, what does that stand for? It's a type of cuff on the trach.